Senator Banks. Banks is next, yeah, I'm sorry.
Thank you, Mr. Chairman. Mr. White, you talk about, in your testimony, you talk about the role of hospital consolidations and the lack of competition. You said nationally, 97% of hospital markets are not competitive. That's certainly the case in Indiana. In Indiana, we have 5 major hospital networks who control almost all of the hospitals in our state. Can you give us a little bit more of a background on how that happened? How did the ACA encourage hospital consolidations and crack down on competition?
Yeah, I think it built off a longstanding trend. We were already at 80% concentration by the time the ACA came online. It just accelerated that trend. And basically there were several things happening at the same time, but a big change was in 340B, the drug discount program available to hospitals. That provided extra cash through markups for nonprofit hospitals to buy up other physician practices, to the point where now 40% of doctors work for a hospital. They don't work for themselves. Pharmacies, and then the second biggest thing was the medical loss ratio, which allowed insurers to vertically integrate with PBMs, pharmacies, et cetera. Those 2 factors were the biggest factors. So we got to 97%, and you say, so what? It means we don't have free markets in these markets for hospital services, for insurance, et cetera. That means prices are higher. So in hospital markets, highly concentrated hospital markets, prices increase by as much as 30% after a merger. And those prices flow straight through to premiums. And that's what everyday Americans are paying for. They're paying for these uncompetitive, highly concentrated markets.
Give us good ideas to do something about it. I mean, in Indiana, for example, we have a strong healthcare merger review law. Our Attorney General gets a 90-day advance notice to review all acquisitions. Is that a good model? Are there other good ideas of what we could do to create more competition in hospital markets?
Yeah, I think empowering the FTC maybe to look more at nonprofit mergers in particular could use some statutory beefing up and enforcement authority. It's hard to get the toothpaste back in the tube, though. These are big buildings, right? It's not like a service company that you could break up. They're highly localized monopolies, and so I think taking a look at the economic incentives is important too. So right now we pay hospitals more for the same service that a physician delivers, and that should probably be the same payment rate so that we don't have these economic incentives. On the input cost side, what we see is those drug discounts through 340B are only given to nonprofit entities, not to for-profits, and so they get lower input costs, they get higher reimbursement, and they use that cash to buy up other entities. So I think local review boards, a more beefy FTC enforcement structure, and changes to how hospitals are actually paid and financed could go a long way towards creating competition. The last thing I'd mention is that what we see in local markets is anti-competitive contract clauses. These force most favored nation pricing clauses. They prevent price discounts. They prevent people in health plans from being sent to a lower cost, high quality provider. The Healthy Competition Act, which Chairman Jody Arrington introduced, would ban those anti-competitive contract clauses and create free markets in those services. That saves $5 billion and lowers premiums.
You've been around the Capitol for a while. Can we find bipartisan support to do some of that, in your opinion?
That bill is bipartisan, yeah, and I think there's a lot of support for saying, look, if we have this much concentration and empowerment of this corporate big health type systems, look, we need to do something about this. This is the biggest cost driver in healthcare today, and I think this committee obviously has a lot of jurisdiction over that.
Ms. Strauss, walk me through how the community rating works and how changing it to a 5-to-1 would bring down premiums.
Yeah, so prior to the ACA, we had the ability to rate people based on maybe their age and risk. So at that time in Iowa, so I lived in a state who had a solution for everyone. So I know one of the senators mentioned, I think it was New Hampshire, that their state had people uninsured completely. We didn't have that in the state of Iowa. If you were ever excluded or ridered a condition out, we had a high-risk pool, which really could be like the marketplace today to help to manage some of those things. So when we had our individual market previously, the younger population was getting rated based on their age and their risk. So we had people in their 20s with premiums that were about $120. Well, when we went to this 3-to-1 ratio, a 60-year-old and now this 20-year-old, all it did was inflated all of the numbers and brought everyone's rates up. So right when we went into the ACA, that same 20-year-old person now had a $300 monthly premium. And these are the people who really weren't using the insurance. They had it for catastrophic reasons. Maybe they had a few things that were going on, but we needed to keep them in the marketplace to keep the rates down, but all we did was inflated the rates on them, so they exited the market, which is what we're seeing today on a much bigger scale. People are just going completely uninsured because in their minds, they don't think they need to have the coverage, especially if they're paying $600-700 a month for their coverage.
Very helpful. Thank you. My time has expired.
Thank you.